For women to come in and just say, I'm sleeping now. I'm not angry all the time. I changed a woman's life by giving her an estrogen patch for what I thought was hot flashes, right? Because she had some hot flashes. She came back and said, I'm not angry with my kids anymore. I'm not an angry person. I was just angry. I've been angry for 4 years and I don't know why I'm angry. And you fix that with an estrogen patch. It's profoundly rewarding medicine.
Welcome back to Innovate and Elevate. I'm Sharon Kedar, your host.
Tonight we have someone who I was blown away by. I went to the FDA because they had their first ever menopause panel. And my doctor, Rachel Rubin, was on the panel. Brilliant person after brilliant person. It's the truth about HRT and what we need to know. What you said at the FDA blew me away. Dr. Casperson talked about testosterone, about how it's so much more than what we think about. You talked about women's brains turning on. You compared it to the Wizard of Oz and that a woman saw in color versus not.
Thank you. Thank you for seeing me. Thank you for being there. There wasn't a lot of people in that room. People were telling me that they were listening because it was live streamed, but people were pulling over crying, listening to that FDA panel. It's free on the FDA's YouTube. It's like a 2-hour master class. They said, come with heart, science, and what the FDA can do to make a difference. And we delivered on the assignment.
You delivered, as you said, with receipts. And so Dr. Casperson has a book out too, if anyone hasn't seen it. It's called The Menopause Moment, and it follows her book called You Are Not Broken. You Are Not Broken is special because it's for women about a topic that we don't typically talk about. Why is HRT so controversial, and can you share what that really means?
I'm a urologist. So urologists commonly treat men. We give them testosterone at 10 times the female dose and Viagra when they ask for help. And so we treat them like the biologic beings that have health issues. And then when women come in, whether it's low hormones, low sex drive, same thing that the guys are coming in for, right? We're like, oh, just try harder and come back when you're suffering enough. Viagra came out in 1998 and it was a failed blood pressure medication. They gave people placebo and Viagra to see if it would lower blood pressure. And they said, this is a crappy blood pressure medication. This isn't working. These men wouldn't give their study drugs back. At the time, people thought male erectile dysfunction was in their head. When you don't have a medication for it, you don't have a treatment. It's not real. This was the first time we said, aha, there's actually a pill that changes your physiology enough. This is a biology problem, not just in your head. So let's repurpose this to much fanfare. Viagra came out. Within the first 2 years, it was the fastest selling pharmaceutical ever, made what is now $1 billion back then. Now, this many years later, we've destabilized the relationship because we've treated this person's sexual function, but never treated this person's sexual function. And my power and voice in this conversation is who's taking care of the people that I'm giving the medications to want to be sleeping with, right? And it's a destabilized relationship. I had a woman crying in my office because of a sexless marriage. I started getting into female sexual health and dysfunction. That's the podcast in the first book. But everybody kept saying, I don't know what happens to sex lives with menopause. So I just kept peeling back the curiosity layers to be like, what's the role of estrogen, testosterone, blood flow, tissue health, collagen? It decreases pain, improves orgasms, all of this, but we're really afraid of this stuff. Where did that come from? I kept peeling back the layers, and the book publishers were like, will you write another book about sex? And I'm like, I think I actually want to write a book about menopause. They're like, great, write that. But the zeitgeist of the menopause movement was starting to take off. And just like female sexual health was starting to take off, menopause was starting to take off. Because Gen X is seeing how the boomers are aging. Gen X is saying, what if there's a different way? And now what's happening because of all the work Gen X has done is the millennials are coming along saying, I'm watching Gen X, I see the boomers, why should I suffer first? And this wave of millennial, why should I suffer first, is rising up against the wave of the healthcare system, which says, are you suffering enough yet? Why don't you come back when you're more sick and we actually have something to treat? So these two waves are happening right now. The millennials are gonna win. 100% the millennials are gonna win, right? So that's where I sit in this intersection of female sexual health, hormones, testosterone, and really saying we can't treat half the population when relationships exist on everybody feeling well.
But isn't it also health? I think about bone health. I think about hormone replacement therapy. Nobody escapes menopause. So if you are XX biology, there will be a period before menopause, and Dr. Casperson will clear this up if I say anything that needs to be medically corrected, but There's perimenopause, which nobody tells us about. I love all the doctors in the audience, but nobody told me about it. And then there's menopause, which is defined as 12 months without your period. And in that time, your hormones, as our mutual friend Tamsin says, run out the door. And so you would think that we'd be like, okay, with all the brilliant doctors here, let's tell women that, let's take care of them. Because to me, when I think about what's causing women living in poor health in midlife, it's not simply because we live longer, it's during our peak years. How much of the health issue is hormone related? Are we doing women dirty here? And therefore their families, this is not in the mainstream world talked about.
Yeah, I think health literacy is really low, and then health literacy goes lower when the organs we're talking about are on the inside and you can't see them.
Okay.
And I think the great misnomer is menopause means no period for 1 year. That's a symptom of actually the ovarian dysfunction, lifespan, however you want to say that. No periods is what happens because of the ovarian loss of hormone production. Ovaries make eggs, but they also make the hormones, right? And these hormones affect every single organ in our body, which is why we say this is not just an OB-GYN problem. This is a human problem. 50% of humans, I would say 100% of humans, because the other 50% are affected by what's happening in this body.
For context, my goal is that people have the conversation with their doctor. Not everybody can take hormone replacement therapy. It's not the answer for everything, but it's estrogen, progesterone, and testosterone. Right now in America, 5% of women are on hormone replacement therapy. We can get into sort of the history of it. For many people, is this right? Like health benefits, like bone protection.
Totally. And for context on that 5%, 40% of women were on hormones in the 1990s.
So we've gone backwards?
Severely backwards.
Yeah.
So for people who don't know, the WHI was a $1 billion NIH-sponsored study that got a bad press release in 2002. The study itself, not bad. Lots of useful things, actually. But it was the press release that spawned this zeitgeist of fear. You ask an average woman, why are you afraid of hormones? She can't say, in 2002, the WHI media, she doesn't know why, it's just in the zeitgeist now. But estrogen, testosterone, progesterone, all made in the ovaries. They act in the brain, the heart, the blood vessels. They help in the creation of cholesterol. You actually make cholesterol to make those hormones. When the hormones go down, the body's smart and says, maybe I should pump out more cholesterol to try to make this. Rising cholesterol, insulin resistance, development of diabetes, and profound changes to the brain. Number one thing that perimenopause, so there's no cliff that just happens on a Tuesday, right? Puberty takes about 4 to 5 years for those ovaries to come online and have regular periods. Perimenopause takes years for ovaries to wear out and us to live longer. And so that's the profound change, because often women will be like, my doctor's told me I can't get treatment because I'm still having a period. Period's a symptom of hormones changing. It's not the thing that which we walk around and say it's periods are your guiding light. Number one symptom that women complain of in perimenopause is not feeling like myself. In medicine, it's very unsatisfying because I can't x-ray that. I don't have a lab to be like, does Sharon feel like Sharon today? I have to know, oh, there's reasons for not feeling like yourself. Your brain is changing because your hormones are changing.
When you talk about all that, what we started with is really important, but when we're talking about basic human functions that get impacted in perimenopause and menopause, my mom, with her doctor, went back on estrogen at age 77 last month, and she's one of what I call the lost generation of women. So the history is the 2002 government study that you're talking about was called the Women's Health Initiative. So WHI stands for Women's Health Initiative, which is why I don't use the words women's health. I think this is human health. What's crazy about that study is there was a press conference called on July 9th, 2002, before the actual study had been released. It was alerted to the press that estrogen caused breast cancer. And what happened is the HRT plummeted in terms of use, and it got pulled out of medical textbooks. So now we not only have to align on what is accurate, but also to understand that this entire well-meaning medical system has not been trained on this issue. So does HRT cause breast cancer? Were those headlines misleading? This is like a whole gap. Women had to flush their estrogen down the toilet because they were scared of and the doctors weren't going to prescribe it. So this is like the 23 years ago history of maybe we're rewriting it.
Yeah, I think we are rewriting it. I think we're on the next elevator ride up in women's health. The first thing to know is that study used, for layman's terms, that study used oranges. What we use commonly in clinic now is apples. What I mean by that is this was oral synthetic 1 dose of medication. What we use now is a different route, and it's what your ovaries naturally make. So when people say estrogen and when people say hormones, we all think we're saying the exact same thing, but there's actually many different types of medications and formulations and routes and dosing. And what they used in the WHI did not increase the risk of breast cancer, the estrogen alone arm. And they used a oral synthetic progestin that's a little bit inflammatory, slightly higher risk, but still not anywhere near alarming of estrogen causes cancer. Because when I say estrogen causes cancer, you think that means all estrogen causes all cancer 100% of the time. You also think something my ovary naturally makes is trying to kill me, right? When you say those words. Instead, what's more accurate is a synthetic medication that your body never made in the first place, that had nothing to do with what our ovaries are making, had some little statistical blips. Remember, the study was never created to look at breast cancer in the first place. It was a secondary endpoint. These people weren't randomized for their risk. And when you pulled the placebo group out that was previously on hormones, because hormones actually decrease the risk of estrogen cancer, nobody's saying that yet, then there was no increased risk in the oral synthetic.
When I was at the FDA commissioner, if you all haven't read the current FDA commissioner book, Blind Spots from 2024, talks about all these sort of what medicine has gotten wrong. And chapter 2 is a whole study of this topic tonight called OMG HRT. And it's all about actually how it was false, the readout when it came to breast cancer. Obviously, it's a sensitive topic, but it also talked about some of the data that is emerging now about, which is important to discuss, but related to dementia. It talked about the number one killer of women being, just like it is for men, for all genders, hurt, and how HRT can actually prolong your life and be cardioprotective. This is all data that was talked about in our current FDA commissioner's book. And so what's so surprising to me, as Marty McCary calls it, outdated medical dogma, but it's still the standard that people are afraid. We're at 5% treatment, and that well-meaning doctors don't have this information because of a study that was poorly run. Have we ever heard of a time when, okay, I'm going to call a press release, but I'm not going to give you, here's a doctor, medical practitioner. I'm not going to give you the information to have information parity. I'm going to hold it back for 8 days and scare the crap out of you. Breast cancer is terrifying.
It's a huge deal. We're living now 3 to 4 decades past our ovarian lifespan. We've never aged that much on a societal global level before. The boomers are the great experimentists from a big standpoint. They're breaking hips, they have dementia, devastating loss to self-worth, let alone family resources. And so Gen X is like, how do we do that different? And then the millennials are like, we don't want to suffer. But it's not so much that frailty is inevitable, it's what can we do now? Because hormones prevent disease. Hormones don't treat disease well. So you actually have to get on this, if you're going to get on it, as soon as your ovaries start going down. That's what the data says. If we want to prevent the dementia, on the horrible day, on that horrible Tuesday that you or a loved one are diagnosed with dementia, it started 20 years earlier.
That gave me chills. That's the whole PSA, folks, because that to me is shocking and unacceptable. You know what I mean? Do you all think people deserve better? When our mutual friend Vonda Wright said at the FDA, if you're born a woman, it's either going to be you or me, meaning 1 in 2 women will have an osteoporotic fracture in their life. She's an orthopedic surgeon. She's talking about Miriam, one of her patients. If you break your hip, 1 in 3 women will die that year. When do we actually talk to women and girls about this? When are we supposed to go and see a urologist? Do we see an OBGYN? Do we see our GP? What do we do?
Yeah. So this is a human issue. It's 51% of the population. There's 40,000 OB-GYNs in the nation for 80 million women over the age of 40. Math doesn't math. And those gynecologists are busy delivering babies, doing hysterectomies. They are very busy already. it is damaging to say 51% of the population needs to be taken care of by 40,000 people. We can't do it. This is all hands on deck. Your skin gets affected, your health after surgery gets affected, your brain gets affected. This is everywhere in our body. It's natural, but we shouldn't need to suffer. So puberty is natural, but I don't want you to suffer through it. I'm going to help you through puberty. Let's talk about the issues that might come up in puberty. Pregnancy is natural, but I'm going to help you through issues with pregnancy. We're going to treat complications of pregnancy, and you're going to know about it. And living longer than your ovarian function is natural, but you shouldn't have to suffer from it. There's consequences that happen from it. You should know about it, and there's options. What we're doing now, because of the role of social media, podcasts, Instagram, women are smart. You give them good information, they make good decisions. We know that. So we're changing this big ship of medicine from the ground up. And we tell women, we're like, I'm sorry, but right now you might go to your doctor knowing more than them about what's going on. And it's because after the WHI, doctors stopped being trained. Interesting statistic, that 40% of women were on hormones prior to the WHI. 40%, top 5 best-selling pharmaceutical in the country in the 1990s. 10 years after the WHI, 10% of American women were on hormones. Now 20 years after the WHI, 5% of women are on hormones. It was a study. When interpreted well, you realized this wasn't that bad of a study. Media made it bad. The study itself was not that bad. Interestingly, that study is free online for anybody who wants to read it and interpret it. And yet here we are with the zeitgeist of fear. So those doctors are like, it's a blip, but this is not that bad of a study. My patients are benefiting. I know this is safe. I'm going to continue doing it. But at some point, those doctors retired. And that's why we had 10 years after, 10% were on. Now 20 years after, 5% were on, because we have 2 decades of clinicians that didn't get trained. I didn't get trained. I had patients crying in my office, and I was like, what's the truth? How can I help? And then became so infuriated by it to be like, you're telling me we're afraid of something that will actually make you live longer?
That's why we're taking the time tonight. So you're saying that the data shows that, and it's not for everybody, but by and large, for a woman in midlife, hormone therapy will have a woman live longer, but she's afraid to take it?
Yeah, so 2 things. Number 1, 2022 menopause guidelines. The guidelines say benefit outweighs the risk within 10 years. Benefit outweighs the risk is a very strong statement in medicine. Medicine doesn't say that about many things. And the other thing I say is that if a man could take a medication between 50 and 60 that made him live on average 2 to 3 years longer, do you think every man would be on that medication? People are like, yes, and it would be in vending machines, right? That medication is called estrogen. And what we've done is we've upplayed the fear and we've downplayed the benefit. People are starting to figure that out. We do lots of things in medicine that have risks and have benefits. That's what medicine is. It's a discussion of risks and benefits. And everybody deserves that discussion.
That's what I think is people deserve the discussion. JAMA, Journal of American Medicine, says that it takes 17 years for updated protocols to reach patients. Currently, and Dr. McCary did say changes are coming, but currently, estrogen has a black box warning. The protocol that our mutual friend Dr. Rubin talked about is 5 things to talk about with a woman, 5 different medicines. So you've got a 10-minute doctor visit, 5 medicines, estrogen, progesterone, testosterone, vaginal estrogen, and then an extra cream that you all talk about. So how are we supposed to do right by American families? How are we supposed to fix this if it takes 17 years on average when guidelines are updated to reach patients?
This is a culture change, right? Big culture issues. Believe women when they tell you, are you suffering enough? The average woman in America has to see 5 doctors to get her menopause symptoms treated. At the same time, women utilize too many healthcare resources. You're too expensive to take care of. You have too many problems. If you don't take care of her problems and she has to see multiple people, then yes, that's true. And what if it's not 8 different problems that you have? What if it's 1 problem that you have? Because hormones affect all the thing. It's not a shoulder issue, a brain fog issue, a bladder issue, a heart palpitation issue. That's all hormones.
How many women do you think are receiving antidepressants and sleeping medicines when they might be starting in the wrong place?
We know they are. 25% of American women are on an SSRI. 80% sexual dysfunction. There goes that destabilizing. Meanwhile, her partner's getting testosterone and Viagra.
80% of women have
80% sexual dysfunction rate with SSRI.
Oh, okay.
That women are not properly consented about. independent association with bone fracture with SSRIs because it works in serotonin. Serotonin receptors are in the bone. I didn't know that. I'm a urologist. So I called my orthopedic surgeon friend. I'm like, do you know that SSRIs are independently associated with bone fracture? And this has been so well studied. There's multiple meta-analyses on this. And the orthopedic surgeons, I didn't know that. And I called my primary care doctor who prescribed this. Do you know that SSRIs have an independent association with bone fracture, independent to osteoporosis? And she's like, I didn't know that. 25% of American women are on SSRIs, and women will tell you, I know I'm not depressed. I know that's not what this is.
But that's what they're given?
That's what I was given. So 25% are on SSRIs, 5% are on hormones. We hear this all the time, the amount of women who are able to then come off of their SSRIs when their menopause is properly treated.
So how do we catch up the system? Is this like continuing medical education? At Health in Vegas, there's a really smart Harvard doctor who was saying that when we had the opioid crisis, we actually trained doctors and required for their licensing that they learn about pain management. She was basically saying that we taught doctors how to prescribe. Should this be table stakes for having a medical license? What's even realistic?
17 states now this year alone have menopause legislature in the state houses. Doctors don't like being told how to do our job by people who aren't physicians. Nobody does. The lawyers like being told how to practice law by people who aren't lawyers, right? Like, it's a common thing. But when we fail so greatly and the change is slow, I think that the legislation is like, that these women are suffering. They're dropping out of the workforce. Bad things are happening. There is this legislation to try to move it. I don't know if that's right or wrong, but I know why it's happening. The 10-minute patient visit with the doctor is strapped for time. There is no time to be curious, to continue learning. So right now we have 1 million physicians in this country. Every single one of them works with a woman who will hopefully outlive her ovaries, because that means she's living long. We all need to know, so how do we change this? So that's the top-down, legislating. Bottom-up, educate the women, because nothing will motivate a doctor to change than 5 women coming in that week saying, I've heard about vaginal estrogen, can I give it a try? I'll follow up in 2 months and we'll adjust the dose as needed, because we're teaching the women how to talk to the doctors. So we've got bottom-up going, top-down coming. The medical schools are getting better this way. We've got the FDA doing great things with making sure labeling is correct. Preserve the sanctity of a box warning. Box warning should be significant threat to life or limb. That's what a box warning means. If your product doesn't actually have that, don't have a box warning. So we've got those changes coming.
And that box warning came a year after the WHI.
Because of the WHI, because of the media. It is really coming from all angles. Societal change. When a woman says something's wrong, believe her. Offer her treatment. So we've got all these different fluxes happening, and where do I see this going? Where do I see us in 5 years? We're going to treat perimenopause a lot better than we are now. We're going to start taking care of the boomers. It really is a wave of the medical system and a wave of people saying, why should I suffer to an nth degree before I'm offered treatments?
And Dr. Casperson is a world expert in testosterone, and in July she talked about how there was not an FDA-approved testosterone. Women on testosterone either needed to use a compounding pharmacy or a tenth of the male dose. So can you just talk to the benefits that you think testosterone have for women? And chapter 4 of your new book, The Menopause Moment, calls it the forgotten quarterback. What do you want folks to know about testosterone?
Things I didn't learn in medical school, right? Ovaries make testosterone. Through testosterone conversion, we get estradiol. You cannot have estradiol in your body without your ovary making testosterone. Female bodies just make about 1/10 the amount of male bodies. And by the way, male bodies make estrogen, right? So this whole like binary, one is one, this one's this one, is just different parts rearranged in different ways. All of our bodies make these things. I've been giving testosterone for 6 or 7 years, and nobody comes back and says just my libido's better. There is not a 1 centimeter box on the left side that's the libido box. Right? Testosterone works in the nervous system by making glial cells healthy. Glial cells are neuron support systems. We've got the support cells being healthier. We've got the mitochondria of the neurons being better. We've got the myelin sheaths of the neurons being better. Testosterone is a nerve neuron drug. It helps the brain. And when people say it's only for libido, I'm like, but what's libido? Libido is motivation. Motivation towards something, right? Also, the dopamine pathway. Dopamine is released on the pursuit of something rewarding, right? So we've got testosterone and estrogen working in the dopamine pathway, and then testosterone specifically works in the motivation pathway. That's why when women come back, they don't just say my libido's better, they say, I actually feel like getting stuff done. I know personally about 8 women who started businesses after they got on testosterone. I just feel like doing stuff. Men say the exact same thing, right? This is a motivation hormone. But again, in medicine, I can't x-ray how your motivation level is. I can't measure your motivation level, right? So it gets stereotyped as this libido drug. So when I went to the FDA, I said, please, when you approve a female dose testosterone, do not approve it for libido, because insurance doesn't cover sexual health. Men have it approved for low hormones. Women have low testosterone because of low hormones. We should have equality in our labeling, because if we make this a sex drug, then women will have to lie to their doctors to get it, or they'll have to pay out of pocket because insurance won't cover it. Now, there was a patch that went up in 2004 to be FDA approved in this country. Excellent safety data, excellent efficacy data. Why did it not get approved? Because it happened right after the WHI. It wasn't because there was too many side effects, and it wasn't because it didn't work. It was just a very unpopular time for hormones. There are now 4 countries in the world that have a female dose testosterone. We have Australia, New Zealand, South Africa, and the UK. I hope America is next, because women's quality of life should be treated as well as a man's quality of life.
If we're talking about like stamina, energy, mental clarity, these are all things that you talk about in the book that are tied to testosterone. The dose might be different, but it's incredibly hard for a woman to access it, let alone pay for it. As a leading doctor globally for women, how does one titrate the dose? So if you're lucky enough, and I imagine the 5% of women in this country who have HRT, that is mostly estrogen and progesterone. Correct me if I'm wrong, but that's probably like a fraction of them are on testosterone. Is that right?
The data is really hard to measure because there's no FDA approved product that we can just check insurance databases. I can't tell you how many people are on it because we can't study it because there isn't a product.
It only helps with mental clarity, stamina, and details like that.
And it also can lower your blood pressure, and it also helps with muscle mass, and it also helps with bones.
Sounds super insignificant.
Yes. So the best data that we have, which is trying to measure pellets and compounded and off-label male doses, to the best data that we have, as many women in this country are on testosterone as men. Men have about 10 products, women have 0. The New York Times article just got published. I was quoted in it. I think they did a fair job because they validated the women's experiences. The things that these hormones help you with are, in the medical world, vague. Feeling like yourself. Motivation to get stuff done. Not hitting a wall at 3 p.m. I can't x-ray that. I can't lab test that. I can't ICD-10 that. But at the end of the day, you feeling like you is the single most important thing that a healthcare professional can help you with.
Yeah, and this is like a minor detail, but I think that for all of the women that birth the entire population, we might want to do what you said. Thank you to Dr. Casperson. I feel optimistic tonight. We're all behind you and driving the change. It's not that HRT is for everybody, but everybody deserves the conversation. American families deserve the conversation. And we've already heard that we're going to have some changes to some of the black box. Maybe that'll be part of the catalyst. Dr. Casperson is part of a really fascinating group to give hope. It's not going to be one person. It's going to be all of us.
Thank you. Thank you for coming today.